thoughts on virtual ward rounds coming to the NHS, especially as a future doctor? And what do you think your patient's reaction might be? Hey everyone, I'm Katie, one of the presenters at the Aspiring Medics and a medical student at the University of Birmingham. And today we're going to be going through 10 NHS-based MMI interview questions to help you smash your interviews. Let's get to it.
Question 1. Are consultant strikes better or worse than resident doctor strikes?
So strikes highlight a delicate balance between staff welfare and patient safety. And if I was imagining a strike at my hospital and considering whether it was a consultant one or a resident doctor one, I'd have to think carefully about the impact that it would have on patient care and the differences between the nature and the goals and motivations of the staff members. So firstly, just defining what a consultant role is. Consultants tend to be the senior clinicians in the hospital. They tend to ultimately be responsible for the final decision, ongoing treatment plan decisions, and also liaising with other specialities in terms of providing that continuity of patient care. They do tend to be also responsible for the more delicate surgeries or big decisions that are made within the hospital, as they tend to be the most senior doctor in charge. Resident doctors are more important for the daily function of the hospital, for example, taking part in ward rounds, communicating with patients, ordering tests and investigations based on the consultant-made plan. So you can tell that they're both vital for very different ways, and their motivations regarding strikes differ significantly. When the consultants strike, it's mostly driven by factors such as workplace conditions, long hours, and also pensions and other related factors. When resident doctors strike, it tends to revolve more around issues like working conditions, long hours, salary, and unstable further training positions. So you can tell already that the motivations are different, and that also leads on to a different factor behind the patient care and the implications of that on healthcare. Talking a bit more about the benefits behind the consultant strikes. To the level of seniority within the NHS, it can attract a lot of media attention and highlight the systemic issues within the NHS and allow the public to have increased awareness of the problem so that we can encourage long-term better workforce development. Talking a bit more about the drawbacks is that it can lead to elective surgeries being cancelled. Emergency surgeries typically do still proceed with the on-call consultants that remain. However, it can have a knock-on impact to patient satisfaction and increase the waiting lists if there's a lot of strikes happening and those elective procedures are cancelled. It can also lead to junior doctors feeling less supported as there's less consultants available for them to relate back to, so that can be an also important issue to consider. Talking a bit more about the resident doctor strikes. When resident doctors strike, it can often leave a big vacancy within the NHS and lead to disruption in continuity of care, disruption in investigations and treatment plans being made, and patients often feel that impact immediately. It's important to consider the negative impact it's having on patient care. Some of the benefits with the resident doctor strikes, however, is that they are able to highlight a clearer purpose to the public as they're able to fill a gap in patient care immediately with the resident doctors being gone, and therefore patients might be a lot more aware why junior doctors are striking, as they're not able to receive the current treatment plan. They might notice absences on the ward rounds. There can be a lot of media attention given to that side of it as well, for example salary and workplace conditions, and really highlight what the role of the frontline NHS staff is. Talking a bit more about my own personal experiences, when I was in my own shadowing experience in a hospital, I noticed that the consultant tend to be the end decision maker and provide a lot of guidance and mentoring to the younger resident doctors. Their role is really important, and when you have a strike action, I can see how the implications of that might be significant, not only for patient care and having those elective procedures cancelled, but also on juniors and how they can make clinical decisions and how they can relate back to a lot fewer consultants. You can see the strain it might have on the system. In terms of more resident doctors, when I was shadowing them, I really saw how essential they were to the day-to-day function of the hospital. Therefore, imagining how a strike might impact on patient care is really significant, because patients wouldn't be able to get those frequent doctor interactions, able to have the tests that they requested as well, that the consultants are requesting, and see how that might cause blockages along the patient care journey and lead to a lot of diagnostic delay in treatment. In conclusion, consultants and resident doctor strikes are both really important to consider and demonstrate a delicate balance between staff morale and advocacy for better working conditions, and also the knock-on impact that might have with patient safety. So it's important to consider why both are striking for very different reasons, and also evaluate how the differences in care with the patient and their different roles might cause a knock-on impact. For example, with the consultants having much more of a guiding role in making that ultimate decision and those surgeries being cancelled, while the resident doctors are more about the frontline day-to-day care that patients might notice more directly.
Question 2. The shingles vaccine was only available to those over 70. The NHS is extending this to those over 50 and the immunocompromised. Why do you think this change has occurred?
Yeah, so recently the NHS vaccination for shingles has been increased from being just over 70s to those over 50 being eligible, and also the immunocompromised. At first this is just a policy change, but when we actually dig down and look at it more closely, it reflects the core aspects of the NHS: preventative medicine and evidence-based medicine. So firstly, shingles is caused by the reactivation of the chickenpox virus and can lead to severe, long-lasting complications when it does reactivate in older adults. Typically, those over 70 and immunocompromised can be more at risk. However, there's been increasing research and evidence showing that even those at the age of 50 and over can be at risk of complications of shingles and severe prolonged pain, which we really want to minimize and avoid as much as possible. The immunocompromised, for example, those who have received a transplant or those with chronic health conditions, are even more at risk of those complications developing and risk isolation, fear due to any remaining scarring of shingles, and also other complications like prolonged pain and suffering. The basis behind extending vaccination for those populations that are more at risk and over 50 can really help to prevent those complications from occurring, and also highlights preventative medicine as we're reducing NHS hospitalizations, reducing the burden on the NHS as patients can often present with the shingles reactivation, and help to encourage timely healthcare intervention and really minimize suffering. Now, talking a bit more about my own shadowing experience. When I was volunteering in a care home, I noticed that shingles can have a profound impact on the residents' lives. For example, one person that I saw was really worried about the scarring it was having on her face, and also had a lot of pain associated with shingles as well. If those kinds of people are offered the vaccination earlier, it can help to reduce the impact that the complications of shingles might have, because it is a significant disease that we want to eliminate the risk of and protect those vulnerable populations. So it's really encouraging that evidence-based research has proven that those over 50 would be eligible for vaccination and reduce the burden on the NHS and reduce the risk of readmission, help to improve patients' quality of life by preventing them from getting the condition in the first place. Now, talking a bit more about my wider reading, the NHS England and the WHO encourage immunisations as far as possible and encourage it for more vulnerable groups, which over 50s have been identified over, so the fact that it's been extended to that is really encouraging. Also, reflecting on the principle of medical ethics, justice, it's important to recognise that extending the vaccination to those over 50 and the immunocompromised encourages equity, as those that are more at risk are able to be protected. In conclusion, extending the shingles vaccination programme to those over 50 and the immunocompromised is a really positive change and demonstrates the core values of the NHS of preventative medicine, using evidence-based research to encourage change and help to reduce the burden of disease on the public, and also improve healthcare outcomes for everyone.
Station 3. How well is the NHS prepared for the effects of the summer season?
Yeah, so at first, the summer might seem like quite a relaxed season where there might be less rates of flu and COVID and those kinds of viral illnesses compared with the winter. It does pose a unique challenge for the NHS, and it's important that the NHS navigate being prepared before the summer season starts. Firstly, talking a bit more about the challenges the summer season can bring. Heat waves are really important to consider because the elderly and vulnerable populations can experience worsening of chronic conditions, can experience heat stroke and other complications related to heat exposure. Secondly, it's important to consider the fact that there's increased accidents and emergencies in the summer season. For example, people are spending much more time outdoors, so we do see an increased risk of sporting injuries, of falls, and also road traffic accidents. An increase in presentations of things like sunburn, which you might not think about in the first incidence. And lastly, we do see a seasonal illness spike as well, so not so much flu, but other problems, for example, norovirus, which is the vomiting bug, and other gastrointestinal problems can also spike in the summer season, along with food poisoning. Now, talking a bit more about the NHS and how they can keep prepared before the summer season starts. Have staff flexibility in working shifts, so often they're able to sense when a heat wave might be coming via news reports, and able to have bank staff and flexible staff rotations available to meet the increased care demand that they're anticipating that might come with that heat wave period. Secondly, there's also an increase in public health campaigns. You might see on tubes or also in GP practices how they might be encouraging keeping good hydration, sun cream to prevent those burns from occurring. That can really help to reduce hospitalisation and encourage self-care in the community to help people before they experience those heat-related complications. Lastly, a lot of hospitals in the summer implement resource planning. For example, they have a summer escalation plan for the emergency departments, which helps to ensure that patient care is being met and the high demand of patients coming in can all have their care needs addressed as well. Reflecting on my own volunteering experiences in a care home, I noticed how badly the summer can impact on the residents. For example, when air conditioning is more limited, it becomes difficult to encourage residents to keep up with their hydration. But having those small interventions in place, for example, just telling someone you need to be drinking a bit more water, that can really help to encourage a good change and help to reduce those risks of hospitalization and dehydration, which often then has a knock-on impact of chronic conditions, and it can help to encourage good management of chronic conditions in the summer when you're implementing those small little changes. So in conclusion, the NHS can help keep prepared with the challenges that summer brings. For example, those important challenges to consider are heat waves, accident and emergencies, and also increase in seasonal illnesses. And the NHS deals with that by improving public guidance, for example, hydration campaigns, and also encouraging wearing a good sun cream, and also by encouraging staff flexibility and having heat summer escalation plans in the emergency department so that resources can be allocated effectively.
Station 4. Parliamentary awards celebrate the work of NHS staff. How else can the contributions and dedication of NHS staff be celebrated?
Yeah, so awards are a really great way to recognise NHS staff. However, there's many other ways that we can recognise their hardworking nature and dedication. Firstly, there can be local and peer recognition. For example, having Staff of the Month, having innovation awards, commendation awards, and also recognition from the wider team of the impact that you've had on an individual patient's care. That can be really highly motivating and be a great way to boost morale in the workplace as well. Secondly, we can have public demonstrations of appreciation. For example, we all remember in the COVID pandemic when people would go outside and bang pots and pans to show appreciation for the NHS and their work. That really helped to boost morale in a time when morale was draining and a time where workers were increasingly burnt out. And also encouraging patients to speak up about their own patient experience and things that they found satisfying in their care, and also highlighting key members that were influential in their patient care journey as well. It can really boost morale and encourage a good mindset in the workplace as well, as you really feel like you're making a positive difference. Now, talking thirdly about the professional and financial support that you can give and the awards you can give that way. For example, giving bonuses, extra days of leave, and offering good training opportunities and mentorship opportunities as well, which help to recognise excellence and dedication to the NHS. Now, talking a bit more about my own shadowing experience. When I was shadowing in hospital, I noticed how even a thank you card from a patient can really help to boost morale. And also staff recognition and a team level and talking about how well someone did their job that day can really help to boost collaboration, teamwork, and encourage more benefits and even better patient care and satisfaction in the future. So in summary, there's a multitude of ways we can recognise dedication, hard working, and foster a good culture within the NHS. And we can do this not only by awards, but also other things, for example, having Staff of the Month, having shout outs, having patients send thank you cards, and also recognise individual staff members that were important in their care. That can all have a really positive difference and really boost staff morale in the NHS.
Station 5. Describe the collaborative roles of MPs in the NHS addressing healthcare challenges and implementing policies for the benefit of both patient and medical staff.
So at first glance, you wouldn't think that the MP was generally involved with hospital care day to day. For example, they're not someone that I usually see when I go to the GP or in hospital. However, they do have a key role in shaping the NHS, for example, through tackling challenges or implementing policies that benefit both patients and staff. Firstly, talking a bit more about the role of an MP. They provide guidance with legislation and policy making. They also are important for oversight and also advocating for their constituents, which involve both healthcare workers and patients. In terms of legislation and policy, MPs have a direct role in voting on laws and parliamentary debates with factors that are related to healthcare, for example, workforce reconstruction, funding, ultimately extensions and looking into evidence-based medicine and how they can make those policy changes. Secondly, they have a key role in advocating for their constituents. For example, when patient groups are concerned with a particular aspect of their care, or staff want to advocate for better working conditions or more greater salary, then the MPs can be responsible for raising those concerns in a parliamentary setting and debating on those important issues. And finally, they have a key role in oversight as well, which they scrutinise policy, they scrutinise the workplace organisation, and can help to ensure accountability with healthcare and ensure that patient outcomes are being met. Next, talking a bit more about the collaborative side, MPs often work with NHS leaders, with clinicians and patient groups directly to ensure that challenges are made, there can be improvement in patient outcomes and health inequalities can be addressed. Talking a bit more about my own volunteering experience, I noticed that in general practice, they were able to extend the Shingles vaccination programme to be those over 50 and the immunocompromised from originally being available for only those over the age of 70. MPs would have a direct role in this policy change, and it's important to recognise the role that they did have on improving patient outcomes and allowing more to be vaccinated. Reflecting more on my wider research, it's been shown that MPs do play a key role in balancing the protection of staff welfare and also ensuring patient safety, and they have a key role in the collaborative policy-making decision-making to ensure that patient outcomes are being met and staff morale is still being boosted and not coming at an expense of improving patient care. So in conclusion, MPs do have a key role within the NHS, for example through creating policies that address both staff and patient safety, through advocacy for the constituents, both their patients' voices and the staff's voices, and also through oversight and scrutinising funding and policies to ensure there's accountability and the NHS is able to function as it does.
Station 6. Virtual ward rounds are being introduced in the NHS. Evaluate the benefit and challenges to consulting patients in this way.
Yeah, so imagine seeing your doctor not from a hospital ward, but instead from the comfort of your own home. Virtual ward rounds are being increasingly used in the NHS, so let's evaluate first the benefits and then some of the challenges involved with that as well. So firstly, talking a bit more about the benefits, there's improved accessibility as patients who are immobile or patients who are immunocompromised or patients who live far away in rural environments might feel more able to engage with healthcare as they don't have to travel far in order to be seen by a clinician, and they don't have to risk acquiring any hospital-acquired infections, for example, if you're immunocompromised. It's also important to consider that patients are in the comfort of their own home, therefore they might be more willing to engage and communicate any issues that they've been experiencing, unlike in the hospital ward where they might not have slept well through the night and might not be able to remember all the details of their clinical history. It's also important to recognise that it helps to improve efficiency as well, as clinicians might be able to see more patients in a shorter period of time, which helps them to dedicate more time to more urgent or more difficult complex cases. It's also important to consider the impact that it has on NHS resources. If patients are at home more, they might free up a lot of NHS beds, which can be really important for those critical peak times in the summer and the winter. Now talking a bit more about the challenges of having virtual ward round based consultations. It's important to consider that not all individuals are going to be comfortable with having a technological platform. For example, older adults with limited technology experience and also those without internet might struggle to adapt to the system. It can help to perpetuate health inequality, and that has a knock-on impact of justice, which is the fourth pillar of medical ethics, which should be ensuring that all patients receive equitable access to healthcare and all are able to have their healthcare needs addressed effectively. It's also important to consider the data privacy issues that might come with having a technological consultation. It's important to consider any data breaches or breaches in consultation privacy of patients. So it's really important to consider that if we're moving to a virtual-based system, the implications that this might have, and it's important to recognise those limitations and address them before the move is made to reduce the risk to patient data being leaked and the confidentiality breaches that could come with that. It's also important to consider the clinical limitations with using a virtual-based platform. For example, it's important for a lot of patients to undergo physical examination, and obviously that's not possible in a virtual setting, so it can leave a lot of patients and the doctors feeling that the clinical consultation is incomplete. It's also important to consider the knock-on impact that a virtual consultation might have on patient rapport and trust building. If you don't have the patient physically in front of you, it can be difficult to read facial cues and body language signs. Those factors in real life can help to build trust. So not having that available can be a barrier to effective communication, and the patient might not be as willing to share all the clinical details with the healthcare professional. When I was volunteering, I noticed that in general practice, a lot of patients really loved the fact that they could book in a telephone consultation from their own home and allow them to share all the clinical details. It was really useful for things like prescription changes or just asking for more medication, because those kinds of things are quite small and they wouldn't necessarily warrant a physical examination. However, conversely, there was a lot of patients that struggled with the technology side of having online booking appointments, and it was a lot better for them to have a face-to-face appointment, and that included more frail patients where it was really important to have those physical examinations to complete their care. I also read in a lot of news articles that telemedicine can really help to shape how healthcare is being delivered, with improvements for a lot of patients and also downsides for others. So it's important to reflect on the fact that we need to have a balance between having maybe like virtual ward for some patients that are more suited towards that, but also having the urgent face-to-face care for a lot of patients that don't feel as suited to having those virtual ward-based platforms. So in conclusion, there's a lot of benefits and challenges when it comes to virtual ward rounds, and those need to be considered before widespread implementation into the healthcare system, on the fact that patients are all individual and will have individual likes and preferences regarding whether they prefer face-to-face consultation or virtual ward-based platform. It's important to assess that before implementing it on a widespread level.
Station 7. How effective is a national 999 call system when accessing NHS services?
Yeah, so everyone knows that for a medical emergency, the number that you call is 999. However, it's a bit difficult to evaluate whether it's effective or not. So in my answer, I'm going to try and break it down into the ways that it is effective and the challenges that the 999 system are currently facing. Firstly, that a 999 service is a very rapid response, and it allows patients to call up with a medical emergency and get timely medical intervention, particularly for those critical life-threatening emergencies. It's also important to consider the fact that they have a triage system in place, which in-call handlers can prioritise the most urgent cases, can also help to give advice to those non-urgent cases to call the NHS 111 number or refer to their GP for any of those non-urgent medical cases. It really helps to streamline resources into those medical emergencies and ensure that patients are getting the timely intervention that they require. Now talking a bit more about the challenges behind the 999 system. First, they receive a lot of very high demand for emergency services, and that combined with resource limitations and staff shortages can mean that patients aren't able to get the timely intervention that they deserve, even in emergency situations. So it's really important to consider the fact that if there's a pandemic or there's peak surge periods, for example the summer or the winter holiday period, that patients are often left waiting a very long time before emergency services are able to reach them, and then in turn causes a delay in treatment of important emergencies and a knock-on impact on patient care. It's also important to consider the fact that there's a lot of non-emergency calls made to the triage system, which can help to divert resources away from those medical emergencies. So it's really important that in-call handlers are adapted to be able to give guidance to the public about calling up on the non-emergency lines like NHS 111 and also calling the GP for any of those non-urgent complaints. And that's another aspect that we have to put more resources towards public education about the meaning behind 999 and what constitutes a medical emergency, so those resources are not being diverted from those critical emergency situations. It's also important to consider that there's inherent service staffing problems. For example, there's staff shortages with the ambulances, there's a shortage of ambulances in general, and it's also important to consider the fact that location does implicate access to emergency services and access to healthcare as a result of that. For example, if you're in an urban setting, there's much more ambulances available in closer proximity, and other than implications of traffic, you're much more likely to have a timely medical intervention for those emergencies compared with a rural setting, which hospitals can be much further away and ambulance services much further away from patients who really do need that emergency intervention, which this highlights a lot of medical inequality within the system as well between the rural settings and the urban settings. Reflecting on my own work experience in the emergency department, I did notice that there was a lot of emergency admissions via the ambulance for a lot of non-emergency cases. So that helps to portray in my mind that there is a lot of diagnostic delay in reaching people due to resource limitation and people not necessarily knowing how to use the 999 service effectively and using it more for those non-emergency cases which could have been dealt with the GP. So in conclusion, there's a lot of factors to reflect on when we're thinking about the effectiveness of the 999 service. It's a rapid response, they have a triage system to prioritise those medical emergencies. However, there's a lot of inherent flaws with the system, for example service delays, a lack of ambulances, and also discrepancy between the rural and urban settings that need to be addressed so that the system can be even more effective and promote even better patient outcomes and patient care.
Station 8. Healthcare workers often neglect their own healthcare. How can the NHS promote effective healthcare for their staff?
Yeah, so often healthcare professionals can be so worked up in taking care of their patient that they do neglect their own physical and mental health needs. And there's a multitude of different ways that the NHS can use to try and ensure that staff are keeping themselves healthy. Firstly, there's a lot of occupational health service involvement in the NHS, where workers are able to get regular flu vaccinations and they have a place to turn to if they experience an injury at work, for example a needle stick injury. Furthermore, there's often a lot of mindfulness sessions and stress relief workshops set up within the NHS, organised for healthcare professionals to attend and be able to alleviate their mind and improve their mindfulness and reflection, which can really help to protect mental well-being. There's also an increased focus in a culture of support and the destigmatization of mental health, which can really help to protect mental health of colleagues and ensure that there's an environment of collaboration and team support. Moving on from that, there is a much greater focus on a culture of support within the NHS and having people there for each other and supporting each other through the difficult consultations and the difficult times where burnout is much higher, and being able to make friends with colleagues and build that social network to keep mental health protected. Furthermore, there tends to be a flexible working pattern and leave pattern which clinicians and other healthcare professionals are able to apply for. For example, if they've had a very intensive shift, they can request their holiday days off in that period, which can help to allow them time to rejuvenate and be ready to come back and be at their best form for engaging with patient satisfaction and improving patient care. In my own volunteering experiences in hospital, I noticed that there were times where there was a very high demand for patient care, particularly in the emergency department. However, it was really encouraging to see that healthcare professionals supported each other and checked in on each other. For example, a lot of them checked in that they had been having their breaks, if they'd eaten lunch. So it's really encouraging to see those conversations are being had and that really nice culture of support being put in place, because that can really have a knock-on impact of patient care when staff are being able to protect their mental health and feel at the top of their form. So in conclusion, the NHS can take a toll on their staff's mental well-being as they're constantly caring for patients, and that can have a knock-on impact on your own mental well-being and your physical health needs. However, the NHS has multiple systems in place, for example, good occupational health awareness, stress and mindfulness workshops, flexible working hours and leave periods, and also that good culture of support that's in place which helps to protect mental well-being, so patient care is at its best.
Station 9. How can the NHS expedite care for patients with sickle cell disease when they experience a sickle crisis?
Yeah, so sickle cell crisis is a medical emergency, and it's really important that staff are able to recognise the symptoms so that patients can get the timely treatment that they need and reduce the risk of those complications from arising. So firstly, the expediting care often involves urgent triage in the emergency department. Staff should be able to recognise the symptoms of a sickle cell crisis and be able to allow fast triage and urgent prioritisation in those emergency department situations. Secondly, the patients have to get fast-acting pain relief and analgesia. It's really important that they get the pain relief as soon as possible because crises can be very, very painful and lead to adverse health outcomes for the patient. It's also important that the patient gets an urgent specialist review. For example, engaging haematologists early in the management of the patients is critical to reduce the risk of complications and improve patient outcomes. It's also important that the patient has a care plan put in place as fast as possible and that alert cards are distributed in relation to the patient so that staff are all aware of what's happening to the patient and to reduce the risk of repeated delays in their care. And finally, it's also important to engage the community and general practice and primary care. For example, it's important that patients are given adequate follow-up and preventative medicine is engaged to reduce the risk of further crises in the future. Reflecting on my own work experience in general practice, I noticed that there was many pre-made plans made for a lot of patients with chronic conditions to ensure that there would be timely management if they were ever admitted and that a follow-up process would be put in place if they were ever in that situation. So that also extends to sickle cell crisis among many other chronic conditions. So in conclusion, in terms of expediting sickle cell crisis and ensuring that the patient is well cared for, there's multiple factors that need to be put in place, mostly revolving around the emergency department involved in recognizing that the crisis is happening, promoting prompt pain analgesia. I also read in my wider reading that ensuring that sickle cell crisis patients are given pain relief within the first 30 minutes can significantly improve health outcomes. That's a really important thing to bear in mind. Also involving specialist care early, for example with the haematologists, and also having a pathway where patients are able to be followed up in general practice is really important.
Station 10. What new services can the NHS introduce to address obesity in children and young people?
So obesity in children and young people is a significant problem for the NHS and it's currently on the rise, so it's definitely an issue that we have to think more carefully about. Some of the ways that we can think about trying to address childhood obesity and young people obesity in particular is firstly encouraging like a multidisciplinary approach. For example, in general practice, we can foster discussions between dietitians, physical health specialists, physiotherapists, also parents and the child themselves to encourage good management plans to support the child in trying to lose weight and encourage healthy eating habits, and also encouraging exercise, which is really important for the child as well. It's also important to consider the role that schools have as well in trying to support the child. For example, we can set up healthy eating workshops, nutrition-based workshops, improving good sleep hygiene, and really encouraging physical education and encouraging things like sports days more regularly. That can really help to encourage children to exercise more, encourage better eating habits, and help the child to have their own self-awareness of what's healthy and how they can maintain good physical health and try and lose weight and prevent childhood obesity. Furthermore, it's also important that we get the parents on board as well. Having parents talks at school about healthy eating and nutrition is also really important to reduce childhood obesity, as they're ultimately responsible for the child's care. And lastly, having regular nurse monitoring as well, where children are able to go and see the nurse and have regular monitoring of weight and other important vitals, can help to identify issues early and help the child to get timely intervention so that there's much less complications of childhood obesity and they're able to lose weight and engage in more healthier habits much earlier under the support of staff, parents and general practice and other clinicians as well. In my own personal volunteering experience at my local swimming pool club, it was really nice to be able to teach younger children how to swim. And in order to do that, we often made activities fun and enticing. And we have to have a similar mindset when dealing with childhood obesity. We have to make activities and getting out and sports enticing for children to engage with, and something that they really want to do and want to do on their own terms, that can really encourage building new friends in different sports and also managing to keep healthy and reduce the risk of childhood obesity and the complications that come with that. So in conclusion, it's important to consider the fact that childhood obesity is a very broad area within healthcare, and it's something that we can try and tackle on multiple different levels. For example, multidisciplinary approach within healthcare and fostering those discussions between parents and a multitude of different healthcare professionals that could get involved. Encouraging healthy eating workshops in schools, which helps to empower the child to take more care over their own health and try and encourage regular exercise, and also having regular nursing monitoring to identify if the child is doing well both physically and mentally, to try and reduce the risk of childhood obesity and any problems that can come with that. And that's it, everyone. Thank you so much for watching the video. I really hope that you did find it useful. If you did, be sure to give the video a like and drop a comment about your own MMI interview experiences, or if you have any questions at all. We have more MMI content coming up, so be sure to subscribe to the channel and stay tuned for our next video where we go over more difficult MMI interview questions. Thanks everyone, bye!